Hello, everyone. Thank you for coming to the second in a series of lectures that we're having here, officially titled Current Issues in Bioethics. This is done in collaboration with the Center for Practical Bioethics. We'd like to thank them for their assistance in putting together this wonderful list of speakers that we have both this fall and next spring. Also, this is streaming live on the web, and the electronic copy of it will be available after today as well. So please feel free. If you were unable or knew of people that were unable to attend today, let them know about the website and let them know that they can watch this and our previous speaker at that site. Now I'm going to introduce Leslie, who will have the honor of telling you a little bit more about our speaker today.
Hi, my name is Leslie McNulty. Some of you know me. I teach occasionally in the bioethics program here at KCU, and I'm a program associate at the Center for Practical Bioethics, where I work with Richard. So I'm very happy to get to introduce him to all of you. Richard works with me at the Center for Practical Bioethics. He's also a professor in the Divinity School at Duke University. At the center, he holds the John B. Francis Chair and Endowed Chair in Bioethics. At Duke, he is the Esther Cauliflower Chair in the Divinity School. I don't know of anyone else who holds two endowed chairs at the same time, so we're breathing very rare air with Dr. Payne today. Besides that, Dr. Payne has a stellar academic pedigree. I also don't know anybody who has attended as many Ivy League schools as he has. His undergrad is from Yale. He has his medical degree from Harvard. He did his medical residency at the Brigham. He has neurological training at New York Presbyterian with Cornell. He trained with Dr. Kathleen Foley at Sloan Kettering, a luminary in the field. He was also a fellow of the Robert Wood Johnson Foundation. He's served on panels of the NIH and the IOM, which is now the National Academy of Medicine. I try and remind everybody because it's a new change. And he currently serves on the board of the Hastings Bioethics Center. The pinnacle of his career, in my opinion, has been his ability to join us in Kansas City at the Center for Practical Bioethics. So please welcome to the podium Dr. Richard Payne.
Okay. Hello. Can you hear me? Great. Thank you, Leslie. And thank you, Dr. Roselle, my colleague at the center and friend for many years. Thank you all for having me come speak to you. It's always great. I went back. I felt like I was going back in time a little bit as I was had a tour of your school and saw the simulation labs, and I even remarked it was almost enough to make me want to go back to medical school. I'm not so sure about that, but thank you. So I'm a neurologist. I mean, my primary board certification and training has been in neurology with secondary certifications and credentialing in oncology and pain and palliative care. I actually don't consider myself a card-carrying bioethicist, but certainly in the context of practicing academic medicine for the past 35, 40 years, I've had to get intimate and to understand and confront ethical issues in the context of caring for desperately ill patients, trying to care for their families as well as the patient, and really and working and thinking with colleagues, sorting through difficult, complicated cases, trying to come to this issue of, what ought we to do? What is the right thing to do given this set of circumstances? What principles do we draw upon? And how do we how do we understand whether we're making moral and right decisions? So that's kind of where my background and where I come from. I thought that for the next 35, 40 minutes or so, I'd focus on an issue that is ubiquitous. It's very important. And I think that almost no matter what area of healthcare you go into, if you're seeing patients with chronic illnesses and conditions, you will have to deal with the fact that pain is a component of and an important part of their condition. And the question is, how should we deal and how do you address pain, and which is often accompanied by a great deal of suffering? The two are not synonymous. Maybe we can talk about that as well. And also then to use pain as a way to reflect back on what are our moral and ethical responsibilities as clinicians, as osteopathic doctors, as allopathic doctors, as clinicians. What are our moral and ethical responsibilities to attend to the pain and suffering in our patients? So I'd start by reminding you or telling you that one of the great religious thinkers, St. Augustine, said that the greatest evil, not a great evil, the greatest evil is physical pain. Now, Augustine said this as he was writing in his soliloquies about the greatest good and the greatest evil, and he actually had chronic pain. And for him, he came to the conclusion that chronic pain was the greatest evil, physical pain, because it had this unique ability, unlike any other condition that human condition that he had encountered. This had a unique ability to interrupt, to interfere with his ability to commune, reflect on God and matters of the divine. And certainly it is true that pain, dealing with pain, is humans, perhaps humankind's oldest problem. And it's interesting, actually, it's only recently really come to the significant scientific and rigorous scrutiny of modern medicine. So in one way you could say it's mankind's oldest problem, and it's organized medicine's youngest specialty. So there seems to be a disconnect there. Pain and the issues that it is associated with pain has been such a problem that the National Academy of Sciences, through what was then called the Institute of Medicine, actually at the time that the Accountable Care Act was passed, actually specified from Congress that the National Academy of Science organize a committee to evaluate the status of pain care in the United States and to make recommendations as to how pain could be better addressed in the country. I happened to be on that committee after many months of study, and we issued this report, Relieving Pain in America, in which we actually found that there are at least 100 million Americans who have pain on a persistent basis, and this is actually an underestimate because this doesn't include children, doesn't actually include nursing home populations. That chronic pain is the most common cause of long-term disability, and we estimated that it's at least a minimum of $6 billion problem in both direct and indirect costs. So significant issue. Here's a study from Research America some years ago, which looked at the impact of pain on quality of life and patients' daily activities. And you see here that either as a result of the individual being surveyed having pain or reflecting on pain in a relative or friend, that 5 to 15, 20% of individuals have had to make significant lifestyle adjustments and had significant impact on the quality of their life with respect to pain. Either had to move from their homes, needed help with daily activities, had changed jobs or profession, or had specific disability and family leave from work. This is a significant problem, no doubt. One of the things we said in the report, because of our cumulative clinical experiences of the committee, from testimony that we took from people experiencing pain and from advocacy organizations, that there seemed to be a sense that the moral and professional commitment of healthcare providers to address pain was perhaps not what it should be. So we made a statement in the report that effective pain management is a moral imperative, a professional responsibility, and the duty of those in the healing professions. So how do we justify this? How do we come to the need to actually make that statement, which after all, some would say, wouldn't that be isn't that kind of obvious? But why did we come to the need to make that statement? And then on what ethical principles are we drawing on to actually justify that statement? So I'm going to show you a couple of cases that actually come from my own personal experience that at least caused me to question the enduring commitments of my colleagues and others to address pain and suffering, and then talk about how we might think about the ethical principles and moral principles underlying and professional and aspects of professionalism that underlie this claim that we have that effective pain management is a moral imperative. So this is actually a real case. It was a patient of mine who was a physician, actually, a 55-year-old gynecologic surgeon who developed what is called the complex regional pain syndrome. Actually, as she was walking out of the operating room, that big, heavy door actually just hit her under the armpit and the shoulder, and she sustained injury, musculoskeletal injury to her rotator cuff and nerve injury, and developed what we used to call causalgia or reflex sympathetic dystrophy. It's now called chronic regional pain syndrome. And she had this unbelievable hypersensitivity to her skin with swelling, cutaneous changes in her arm and hand, severe burning, and on our pain scale, she rated it at 9 out of 10. It was also associated with autonomic changes. She would have reflex hypertension, sometimes to dangerous systolic levels. Over 220 millimeters of mercury systolic were measured during some acute crisis of pain. And she was totally disabled in terms of being able to work as a doctor, certainly to work as a gynecological surgeon. And it affected all aspects of her life, including her marriage. She went to several physicians in her local community, and although she did get some relief from high doses of opioid medications such as oral hydromorphone dilaudid and oral extended release morphine preparations, her relief was only partial, but it typically gave her enough relief to be able to at least get through for day to day. But there came a time when none of the physicians, none of the healthcare providers in her community were willing to continue to prescribe these medications for her. And she had the impression that she increasingly became a burden to them, that calls weren't returned. When she was in the emergency room with various pain-related crises, she didn't feel as if she was respectfully treated. So she actually sought treatment in another part of the state, and that led her to New York City, where I became her doctor. By the way, she also, as part of this, had a definite perception that her healthcare providers had a gender bias in the sense that her pain was not, it was her perception her pain wasn't taken as seriously as it might have been had she not been a woman. In our clinic, in our multidisciplinary clinic, we did a number of manipulations and interventions that were both anesthetic, that were physical, medicine in their approach, physical therapy, occupational therapy, anesthetic interventions, surgical interventions, and eventually came to a pain treatment plan in which she was maintained on oral opioids at moderate to high doses. She moved to another city to start her life over again. Her husband had gotten another job in the other cities that was in the hundreds of miles away. So her care was transferred to another set of doctors who basically kind of repeated the same kinds of behaviors that had occurred prior to her seeing us. And eventually this became intolerable for her, and she put a gun to her head and killed herself. She is one of two people in my personal practice over the last 35 years who've committed, I can say, have committed suicide as a direct consequence of poorly managed pain. Here's a second case, not a case of suicide, but a tragic case nonetheless. This is, you're looking at a leg of a man who's actually also a physician. He was a cardiologist who had sickle cell anemia. What you're looking at is an ischemic ulceration that was related to his disease. He was in a fellowship in a major program in Houston, Texas, a major cardiology program. And despite optimization of his sickle cell therapy, which included hypertransfusions, included hyperbaric oxygen therapy, included hydroxyurea treatment, and state-of-the-art optimization of his sickle cell disease therapy, he had this non-healing ulcer, which I think you can see from the screen would be painful, and actually was required daily dosing of oral opioid analgesics. Because he was a physician in a training program and knowing the sensitivity of individuals around opioid issues, I actually required him to do some extraordinary things. He had twice yearly neuropsychiatric testing. I talked on a monthly basis with his training program advisor, and on a regimen of transdermal fentanyl, oral hydromorphone rescues, and a lot of psychological support. He actually successfully completed his training program, did cardiac catheterizations, authored several papers, graduated, and went off to another state to practice cardiology. However, he was denied a medical license by the medical board simply because he was on an opioid therapy, even in the presence of having normal neuropsychological testing, and had no evidence of impairment or abuse or addictive behaviors. And in the context of litigation with the state medical board, and a state that I will not name, he actually developed complications of a sickle cell disease and died. So here we have another case where we have someone with a significant pain problem that met difficulty and certain a sense of insensitivity on the part of providers. There's a longer even story to this than I have time to tell about breaches of confidentiality, et cetera, that occurred here. So these are just to give you a kind of examples of kinds of things I'm talking about, and there are studies, there are meta-analyses that have looked at multiple studies of perceptions of patients with chronic pain that essentially tell the same kind of story. So what would be the ethical principles that we should look at in terms of how these kinds of cases and others might be managed? And how would we then understand these ethical principles as a gateway to more appropriate management. Now, I always think of modern bioethics as having really started about 35 or 40 years ago after some seminal papers and reports in the New England Journal of Medicine in the 1960s and the Belmont Report in the early 1970s that have basically laid groundwork for what I think we would all say is the kind of a common which is the foundation for bioethics now, which is a kind of a principle-based bioethics, thinking that we ultimately must have respect for persons, that we must practice in a way to promote beneficence, and that we should look at, and justice is an important consideration. However, this modern bioethics is informed by philosophical thinking and religious tradition and ethical thinking that's more than 2,500 years old. So we can go back to the Hippocratic Oath, which is perhaps the oldest and most famous statement of medical ethics, written, although it's ascribed to Hippocrates. It was actually written probably a century after Hippocrates lived, but raises the question of what moral duties go back to the beginning of medicine and should be associated with medicine. Of course, many medical and osteopathic students take this oath at the beginning of training. The old traditional oath pledges respect to the master to teach other students, and says, I will use my power to help the sick to the best of my ability. I will abstain from harming or wrongdoing any man by it. It has prohibitions against giving a fatal drug, against abortion, doing abortions, having sexual contact with patients. It has prohibitions against sharing confidential information, as it even goes back to the Hippocratic Oath and back that far. There's a modern rendition written in the 1960s. And this version, I know, was by Dean Louis Lasagna at Boston University Medical Center. And part of the modern rendition of this Hippocratic Oath goes something like, I will remember that I do not treat a fever chart or a cancerous growth. That is, my moral obligation is to resist objectifying the person with disease, right? But that I treat a sick human being whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I'm to care adequately for the sick. I will remember that I remain a member of society with special obligations to all my fellow human beings, those sound of mind and body as well as the infirm. The reason I put that in red is I think this notion of responsibilities to the greater society that many healthcare providers have see is as important responsibilities may in fact sometimes be in tension with a primary fiduciary responsibility to their patient, that is to always hold the patient's needs and as their first responsibility and obligation. And I think particularly in the field of contemporary pain management, these two issues have clashed or in tension. And I will tell you in those two cases that I talked about, this clearly was an issue with, as I talked with colleagues and consultants about those patients, there were clearly a lot of tension between, I not only have a responsibility to try to manage this patient in front of me, but I have a responsibility to see that drugs aren't diverted and to not contribute to what has now become known as an epidemic of prescription drug abuse. So there's this tension. And this is a tension that one could say is encoded even in kind of modern translations of the Hippocratic Oath. I'd remind you that the Hippocratic Oath does talk about competency, clinical competency, helping the patient, doing no harm, respecting the patient's vulnerability, but really doesn't mention specific constructs or concepts of autonomy or, quote, respect for persons or duties to the poor or disabled. I mentioned that there are religious foundations that inform current medical ethics perspectives. The three central religious traditions in the West, Christianity, Judaism, and Islam, all adopted the Hippocratic Oath and its call to put patients first within their kind of religious traditions and customs. All had a sense of a religious calling. This is something that should be ascribed to healthcare practitioners, to physicians in particular. All emphasize the obligation to treat the poor. And as this French surgeon in the 1800s says, give advice to the poor for love of God only, but the wealthy should be made to pay dearly. So there was this sense within the foundations of medical ethics that we had a specific obligation to treat the poor and to call upon and to look upon what we do as a calling and not just as a job. Now, but the sense of religious calling actually goes back to not so much the Hippocratic Oath, but to this prayer of Maimonides, who was a Jewish physician and philosopher in the Middle Ages. And Maimonides' prayer, and here's one small portion of it, says, in thine eternal providence, thou hast chosen me to watch over the life and health of thy creatures. I am now about to apply myself to the duties of my profession. Support me, Almighty God, in these great labors, that they may benefit mankind, for without thy help, not even the least will succeed. So the tradition, the Maimonides prayer and Judeo-Christian in particular traditions have clearly informed our current notions of what it means to be a healthcare provider, a physician in particular, and what moral positions we should take as healthcare providers. However, there's also been an overlaying history of paternalism in medical ethics. And in fact, a central indictment of professional medical ethics before the late 20th century was this notion of paternalism. And a lot of the kind of foundations and the evolution of modern bioethics over the last 35 or 40 years really does occur as a reaction and a pushback on previous paternalistic instincts and notions of medical practices. This is probably best characterized by this famous saying of Thomas Percival, a British physician, who in 1791 said, a physician must unite tenderness with steadiness. And this is an amazing phrase to me, which is why I put it in red, condescension with authority. Condescension with authority, as to inspire the minds of their patients with gratitude, respect, and confidence. Actually, in the mid-1800s, in the AMA Code of Ethics, there was a lot of talk in the initial code about patient duties to physicians, to not burden or to not make the physician weary with, quote, tedious details or events or matters not appertaining to his disease, or to avoid discussing diseases during friendly visits or calling physicians during the hours devoted to meals or sleep. So these were actually phrases in the Code of Medical Ethics by the American Medical Association in the mid-1800s. So it gives you a flavor of the tone, right, of these, which are certainly paternalistic. So, however, in talking about this and in moving toward, what we would, I think, most all agree would be more appropriate principles and precepts of ethics, which were non-paternalistic, it's hard to, I think we need to focus less on what, I think we would be well advised to focus on how doctors and healthcare providers should behave and to what extent these ideals should be exemplified in practice. We shouldn't make saints, or we shouldn't look at this from the perspective of hagiography, but we should really focus. I mean, I think there is a value in looking at the lives of physicians who are beacons of practicing appropriately, ethically, and how that serves as role models for us. So that brings us back then to current kind of notions of medical ethics and professionalism, particularly in the context of pain, but other clinical conditions. We tend to define professionalism now as very much competency-based. I remember having discussions with some of my colleagues in oncology, right, as we were fighting this war on cancer, fueled from 1971 by the National Cancer Act, signed by President Nixon, the establishment of the National Cancer Institute, and all of the resources and great science that has developed over the last 40 years following this, where clearly many in the oncology space see compassion and as competency, to see the goals to see palliation being intimately tied, and there's some sense that there is a correctness here, but it's not the whole story. Seeing palliation as critically tied to a sense of how excellent one is in treating the underlying cancer. So we've tended to look at notions like professionalism, particularly around pain management and conditions which are fundamentally subjective. We've tended to define professionalism as certification-based. We've tended to look at try to get to more objective standards of care, to define what is evidence and what is, and we've had a rhetoric about we need to do things that are patient-centered, but no one has really defined well what that means, and often in practice, patient-centered looks a lot like what's most important to doctors and to healthcare providers, and not necessarily what patients themselves would necessarily see. But nonetheless, we have a kind of rhetoric that patient-centeredness in terms of our approach, practicing care that's evidence-based, and that we've written standards of care, and we have certifications and qualifications of individuals, that these are the essential components to what defines the highest standards of professionalism. The American Board of Internal Medicine recently issued 10 professional responsibilities of excellent physicians: competency, being honest with patients, having a high regard for confidentiality, having appropriate as opposed to inappropriate relations with patients, improving access to care, commitment to scientific knowledge, and having a professional responsibility to care for other professionals as well as oneself, are all things that are now seen as responsibilities that promote professionalism and ethical practice. And the American Board of Internal Medicine issued a physician charter, which has 3 fundamental principles. The fiduciary response, what I call the fiduciary responsibility, the primacy of putting the patient's welfare first, a respect for patient autonomy, and a notion of social justice, that is promoting the fair distribution of healthcare resources and eliminating discrimination. One of my mentors, Eric Cassell, who's written some classic descriptions and and has written quite elegantly about the nature of suffering and the goals of medicine. In this classic New England Journal article and in several books, says this about professionalism and the goals of medicine: the ability to provide compassionate attention to the patient as an individual with unique values, life experiences, family interactions, trustworthiness, and self-discipline are what are the required characteristics of the good physician. Dr. Cassell, Eric Cassell, is basically has written and studied the notion of suffering, and makes an important point that suffering occurs to bodies. Suffering is not, and therefore suffering is distinct from notions of nociception, from pain receptors, and suffering can occur in the absence of pain. And what suffering is really all about is a condition, a clinical condition in this context, in which the patient's sense of a threat to the intactness of their integrity as persons is under assault. And that's the essential factor that promotes suffering. Suffering is always about anxiety and fear of the future. Pain and suffering can occur, but you can certainly, for example, in the context of grief, have suffering without physical pain. And there can even be pain, physical pain, without a whole lot of suffering in context where pain is relatively acute, and the individual suffering this pain can either be extremely distracted or find some meaning to ascribe to that pain that actually mitigates their sense of a threat to their integrity as persons. So then how does this come into play when we think about pain management? How does this notion of this clash, or this how does the sense of a clash or a concern about operationalizing the best in our traditions of medical ethics come into tension with what's happening in chronic pain management, and which then might be manifested as some of the problems that I illustrated with those cases? I'll bring up the specific issue of a practice that has come into common being with respect to pain management, and that is the administration of what are now called opioid contracts or treatment agreements. These are usually paper descriptions in which a healthcare provider, a physician, will ask a patient to sign to commit to practices or behaviors that would be required for them to be treated as a patient in their practice around pain management. These agreements or treatment contracts first came into the literature in the 1980s, and they were really borrowed from a practice that came out of the addiction medicine specialty, in which these kinds of written contracts and agreements were more common. But it's interesting now that there are about 10 states, and I'm looking here, I don't see Missouri or Kansas are actually in the group that have no legal or regulatory requirement right now, but there are 10 states in which there is, within the codes and regulations of the Medical Practice Acts, there are now requirements for physicians to have some form of these agreements or contracts in order to prescribe opioids to their patients. Some of these are much more prescriptive than others. For example, in Florida, Kentucky, and Arkansas, one must have a written informed consent or agreement for patients available in the record for patients with pain who are, quote, at risk for non-medical use. For other states, simply require a treatment. This is in the state of Washington, I mean, the state of Oregon, these agreements before initiating treatment of intractable pain with controlled substances. So there are 10 states, and there's actually pressure to have some sort of requirement for this in other states. And this comes from, a lot of this has actually been driven by the so-called opioid epidemic of prescription opioid deaths. I don't want to get into that specifically, but this line here in the graph, you get a sense that if that's the percentage of heroin-related overdose deaths that have occurred since 2002, you see that number's going up, and it turns out that approximately people who are on prescription opioids have about 40 times more, are more likely to abuse or to be dependent on heroin, according to the Center for Disease Control, although some people are actually disputing those numbers. So that's the context. These opioid agreements then started out as tools to educate patients about the treatment plan, to inform patients about risks and benefits of treatment, to clarify treatment agreements, goals, and mutual responsibilities, and to promote adherence to treatment. These were the initial goals, and these are reasonable goals. However, over time, what's been layered are more and more of a sense of a requirement and a language which has been more punitive. You must do this or you will be denied this kind of therapy. And in fact, some people now are claiming that these kinds of agreements are really not agreements, but are, quote, adhesion contracts, prepared by one party to be signed by a party in a weaker position, usually someone who has little choice about the terms. And I think that does fairly describe the position of many patients. We looked into this opioid agreement environment. It's one of the things that we did at the Center for Practical Bioethics, because our arguments there were that there's limited evidence that these kinds of agreements are in fact effective in achieving their goals. Because of the punitive language that we had seen, and many of these, we had a concern that they were doing more harm than good. And again, the evolution from kind of promoting an understanding of mutual responsibilities, it kind of morphed into being kind of regulatory and legal objectives. And so the question is, are they ethically justified? And there's still a lot of controversy about this, but I think an appropriate patient-centeredness approach would clearly say an appropriate ethics approach, which moves away from paternalism, would say that we need to structure these kinds of agreements mostly for people who we can document are at highest risk for abuse, even though they also have pain, and that the language should be, and that the process should be more of a process which will meet muster as being voluntary in terms of the patients and participation, and which is not coercive. And that would meet more of the requirements for a consent, informed consent kind of document, as opposed to a contract document. So here's an example of a very specific policy piece and a very specific clinical practice that needs to be informed by a sense of one sense of medical ethics and one sense of how important it is to address pain management. And it's almost like, as I think about this, it almost becomes a philosophical issue too, because there's certainly colleagues who I've talked to have had the sense that, Michelangelo famously said, I see a block of marble. I don't see a block of marble. I see the David. I see the Pieta emerging from a block of marble. I almost get the sense in talking to some of my colleagues that when they see a person in pain, they don't see a person in pain, they see a substance abuser about to emerge. And so the question is, how do we actually see patients? How do we actually square with our the perceptions, and what are the realities, and what principles are we using, moral, legal, ethical principles are we using to justify the policies and the access or lack of access to important treatments in patients with pain. So I was fortunate to train with this fellow, Dr. Ray Hood, who, if any of you are doing clinical medicine and have prescribed analgesics, you might note that on the floors there are all of these charts which says if you give this amount of oral morphine, that's equivalent to 3 times that, or a third of that amount in parenteral, and the amount of the potency of oral morphine can be compared to the potency of oral oxycodone. And all of that work comes from Dr. Hood's work at Memorial Sloan Kettering. And this is Dr. Bonica, Frank Bonica, who wrote the classic textbook, Management of Pain. Both Dr. Loge and Dr. Hood, they were contemporaries. They're both now dead. But they had a vision that we should be, that when we are addressing and managing pain, we should not be objectifying this. We should be addressing the issue of the person with this pain problem, and our ethics and practice should flow from a sense of understanding the humanity of the individual who has the conditions. So let me give you some other examples of the problems that we get into if we don't see the humanity and if we don't take the time to understand the full patient story. So this is actually another one of my patients, and my only excuse here is that I was a very young doctor when I encountered this patient. But he was an elderly Italian generation man, a first generation Italian man. He had metastatic prostate cancer, every bone, spine riddled with cancer, terrible physical pain, moaning, groaning. This was actually in the days before patient-controlled analgesia pumps and in the days before cell phones. And he was in the hospital in New York City. I was a newly minted attending physician, and I went with my team and I said, you know, our goal is to make sure he is pain-free. And so we created a treatment plan in which we, based on his pain report, gradually escalated his intravenous morphine dose as often as every 30 minutes if needed to control his pain. Several hours later, I was actually paged by not one of the residents or medical students, but by the chief of pharmacy at Memorial Sloan Kettering Cancer Center, who said, Dr. Payne, if you persist in this course of treatment, your patient will consume the entire parenteral supply of hydromorphone, which is what we had him on, before the weekend. So having thought I had killed this patient, I ran back to his room, and he was actually only slightly groggy. He did not suffer respiratory depression. He was breathing on his own because he was actually highly tolerant to the respiratory depressant and sedative effects, but he was still moaning and groaning in pain. And I did then what I should have been more careful to do, is I excluded everybody from the room. I pulled up a chair, sat down, and I started talking with him. Now, it was a little difficult because he didn't speak English well, first generation Italian. But we got through the story, and actually I had one of my social work colleagues help me. And basically, the issue was, yes, he had a lot of physical pain from his metastatic cancer, but he really was suffering with the realization that he was dying and he would never see his great-grandson in the old country. Now, what's the point here? The point here is I could have given him 17,000 milligrams an hour of hydromorphone, and it would not have addressed this sense of suffering because I won't see my great-grandson. I told this story to this remarkable woman, Regina Holliday, who is an artist and a patient advocate, and she represents doctor stories by painting representations on clothing. That's me with the bald head there, and I'll give you a close-up. But So her interpretation of this story is, you got to listen. You got to use the therapeutics appropriately, but the fundamental issue which dominates this thing is the patient resting in a bed of ears because you have to listen. This is not so different from Cicely Tyson, the founder of hospice and modern hospice, who talked about the construct of total pain, that is pain which is not just only physical, but psychological, social, and spiritual. And she actually describes this case of a Mrs. Hinton in St. Joseph Hospice, where she had this aha realization that this is what pain was really about, and that therefore we had to have a comprehensive approach to assessment and management. And this was even actually, for those of you who want to read this, if you read the book, The Death of Ivan Illich, have any of you read this? This should be required reading. Required reading. Short story. You can get it on Amazon.com for 50 cents. It's only about 125 pages, but Tolstoy has the most vivid descriptions of the distinctions between pain and suffering, and gets into issues of like truth-telling and honesty between patients and doctors, so it's required. But in the story, Ivan Illich is a mid-level Russian bureaucrat who's dying from a horrible, intractable abdominal process, probably cancer. He understands that the doctors are lying to him. He understands that his patients and friends are not, his family and friends are not terribly being supportive. They're being very superficial and gratuitous in their interaction with him. The only person who really helps him is the hero of this short story, a person called Garrison, who sits with Ivan Illich, changes his bedpans, and listens to him. And there's this description on page 71 of this story. After supper with his friends, after supper, his friends went home, leaving Ivan Illich alone with the knowledge that his life had been poisoned by this illness, and that his life was poisoning the life of others, and that far from diminishing, that poison was penetrating deeper and deeper into his being. That's suffering. I can give 17,000 milligrams of morphine, and that's not going to address the sense of a poisoning penetrating deeper and deeper into one's being. In fact, later, Tolstoy says, they gave him opium and gave him morphine injections, but this brought no relief. Right? So what does this say? It says that we have to have a medical ethic, a sense of a mission and practice that makes us more like Garrison and less like the Dr. Payne, who was going to consume the entire supply of hydromorphone at Sloan Kettering, and a misguided attempt to control pain. It says that we should medicalize suffering, that we have that is to say. So this to me is anathema. Here's a New York Times piece, how psychedelic drugs can help patients face death. And I say, really? Is that really what it comes down to? No. But underlying this is a sense of what do we see as our goals and ends, and the way in which we need to approach a medical ethic of practice. So I will end by saying, okay, so what's the solution here? So how does this all come together? Here's a famous painting. John Field's painting of the doctor, this famous painting of the doctor sitting there with the dying child on the pillows, the anxious father behind the dying child, and the doctor contemplating. And you have a sense there's nothing the doctor can really do to reverse the process, but he's there, he's present. He is compassionate in the Latin sense of he is suffering with that patient and that family. That's great. It's a very romantic, great notion, and I don't want to minimize that. In fact, I'm saying that it would be great for us to be able to have more of a sense of this, of the roots of compassion, to be really suffering and contemplative with our patients. But how do we more get there? So what are the essentials for formation of the compassionate comparing physician and contemporary medical practice. Now, I know you guys are Kansas City Royal fans, but I grew up in New York. I'm a New York Yankee fan. I still remember the famous George Brett game, too. And Yogi Berra just died, so I couldn't resist this. One of the most famous Yankees. Yogi Berra, you know, he had all those malapropisms, right? One of the most famous is, you can observe a lot by watching, right? And I think that, like that Dr. Field, the Fields painting of that doctor, you know, watching, listening to the story of the patient is critical to really doing pain. Here's another lesson that I love to call on, the Godfather lesson. You know, how did the Godfather's teaching his son, you know, how do you stay ahead of these cronies who are trying to kill you? What did he say? He said, Michael Corleone said, my father taught me to try to see the world as others around you see the world. When you do that, you realize anything is possible. What this is calling for is a practice in which we get out of our white coats and we get more into a sense of trying to understand the sources of suffering in our patients, really understanding why my patient who was dying but was really, and who had physical pain, was really suffering because he would not see that great grandson. And then, you know, so it was possible that he would consume the entire hospital supply drug. So this is about being competent to hear the story, a medical narrative, a story with a teller, a listener, a language, a character, a plot. Or understanding the sickness unfolds in stories. And I saw the great simulation labs, and that's great. And I understand you have great courses here in communication, or at least your competency and your ability to communicate is tested. And I would hope also that as a component of that is that you're being taught a competency around not just eliciting the story, not just getting the basic facts of the story from the patient, but eliciting the subtleties about the story of the illness, which is what people like Rita Sharon, and a physician at Columbia, and people like Arthur Frank, a medical sociologist, in their books have called narrative competence. So, to conclude, how do we meet the moral obligations to attend to pain and suffering? Well, we certainly don't practice paternalistically based medical medicine, but we do act with the highest degree of professionalism. We do have to have established competency, but competency is not just a knowledge and application of knowledge in pharmacology, physiology, diagnostic testing, etc. It is also a competency in being present and listening to the story. And why would we do this? Because we have a fundamental ethical principle that we have respect for the person, and we do not objectify the person with disease. That we have compassion, but compassion is the true meaning of compassion in the Latin, from the Latin root of suffering with, being present, not an absolute commitment to not abandon the sufferer. In the clash of our responsibilities to patients as opposed to broader responsibilities to society, yes, this is tension, and I think it requires some careful negotiation at times. But our first goal should be a reaffirmation of our fiduciary commitment to patients as our primary value, but as we also affirm a commitment to public health and justice. So I'll end by this quote, which is one of my famous quotes by, of course, Nobel laureate Albert Schweitzer, Peace Laureate. We must all die, but if I can save him from days of torture, that is what I feel is my great and ever new privilege. Pain is a more terrible lord of mankind than even death itself. And because of this, we need to ground ourselves in the best practices of medicine that are ethically, morally based. We need to fulfill our responsibility. And we need to establish the kinds of competencies that will be most effective in addressing the needs of our patients in pain, because as Augustine says, there's a sense that it is the greatest evil. So that's my story, and it's exactly 12 by my clock, so I will stop. So thank you very much. Do we have questions? Is there any time to take questions? I'd be happy to, but if we don't have time.
If you have a question for Dr. Payne, you can come down for just a moment and talk to him, but then I will just come off to this 1 o'clock.
Thank you.